Terrific, thank you. And good morning. My name is Risa Lovizo-Mori, and I'm the President and CEO of the Robert Wood Johnson Foundation. I'm thrilled to be here and want to thank all of you for joining us today, especially Tom Del Banco and Jan Walker for allowing me to be part of this Open Notes event where we're going to learn a tremendous amount. You know, when Tom and Jan first began this journey several years ago, they asked a simple but revolutionary question. What would happen if we gave patients access to the notes that we as physicians write about them? Now, it's a revolutionary question because even though patients have access to this information, they have long been able to get access to their medical records. We know that patients rarely actually ask for them, and doctors rarely give them their notes, at least without being asked. So the topic generates a lot of strong feelings, a lot of emotions, and that happens on both sides of the examining table. So I have to admit, when I first heard about this, I was a skeptic, like most physicians who first see this. I started thinking about all the things that are valid concerns that physicians might ask about this kind of a project. Wouldn't this, after all, burden me as a physician? I mean, there's many things that we're being asked to do. Isn't it going to take more time? Aren't I going to find myself spending time reassuring patients about things that they see in the notes? Won't they read things that they don't understand? Think about, for those physicians in the room, trying to explain to a patient that SOB means that they're short of breath, not that you think they're a difficult patient. And probably hardest for me as a physician was thinking about, well, won't I have the natural tendency to censor what I write, to change the documentation because of some concern I might have? And so I was a skeptic. But then I put myself in the patient's position and thought about some of the situations that my family members have been in when they are patients themselves. And I thought about the dynamic in the examining room and how much we ask patients to do during those very short visits. If you think about it, patients are worried and stressed, and sometimes they're actually physically uncomfortable when they come to the physician's office, and yet we're asking them to learn things, remember things, do things that are important for their care despite all of this anxiety and physical discomfort that they might have. So giving patients access to these notes, to the information about them, so that they can actually read it and look at it when they're not stressed, when they're in their own homes and comfortable, just seemed like the right thing to do for patients. It's human nature. We tend to do things if we understand why we're being asked to do them. And it seemed to me that that would be something that Open Notes would offer. And then I reflected on my own experience as a geriatrician and how many times I have been in an examining room or in a situation where the patient wanted to have their adult child or caregiver there to help interpret what was going on. But the problem is everyone leads a very busy life, and often you couldn't schedule those visits for a long time because people were across the country or they're busy with their kids and other responsibilities. Those kinds of delays, I reckoned, wouldn't happen if we had Open Notes. So as I weighed the concerns versus the benefits of Open Notes, it seemed to me that the weight of the evidence was such that we really needed to understand this better. And that's why the Robert Wood Johnson Foundation undertook this year-long study to see the evidence. We wanted to know whether Open Notes as a concept would work. We wanted to find out whether there was value that the patients perceived in this, and whether the doctors would see benefit, and whether the benefits actually would outweigh the potential risks. So I'm here today, as I said, delighted to be here today, because after a year of testing, I think we can very clearly say that whether you look in organizations on the East Coast or the West Coast or someplace in between, the evidence across different cultures and patients and types of physician practices suggests that this works. And we feel very strongly that there's a case for moving forward, and I would say moving forward very quickly. What we've learned, and what you're going to hear over the course of this morning, is that reading doctors' visit notes does not confuse patients. It didn't impose a burden on the doctors, and most importantly, there's evidence that it actually improves care. You're going to hear from the leaders of two large healthcare systems that have very different approaches to how they do their work. Kevin Taub from Beth Israel Deaconess Medical Center, and Eileen Whalen, who's from Harborview Medical Center in Seattle. I think what you're going to hear from them is that Open Notes really does have the potential to be a game changer. And as you hear those results, keep in mind, I'm no longer a skeptic, and I was probably, as the people at the foundation know, one of the biggest. I believe quite simply that Open Notes are the right thing to do. It's the right thing for health professionals, because healthcare is not something that we do to patients. It's something that we do with patients. And as Tom Del Banco says so appropriately, nothing about me without me. It's right for patients because it's right clinically. They are more engaged, and when patients are more engaged, the care that they get is safer, it's more effective, and we know that if patients have information about their visits, they are more engaged. In fact, 85% of patients reported that they would choose a doctor or a hospital that had Open Notes over one that didn't. Now, the Robert Wood Johnson Foundation didn't fund this study simply to ease the minds of skeptics and to silence them on their concerns. From our perspective, Open Notes squares with our mission as a foundation. We believe that where people live, learn, work, and play has an impact on their health and well-being. We also know that personal responsibility plays an important role. Open Notes is a tool that people can use to really own their personal responsibility. It empowers them with the knowledge that they need to get healthy and stay healthy, and it strengthens the partnership between physicians and healthcare providers and patients because it improves transparency. And I think transparency is essential for improving the health of patients and the quality of care that we can deliver. The concept of Open Notes, though, is going to require a culture change, and that, no doubt, takes time. Patients have long perceived that their medical records are a mystery that is locked up in a box somewhere, and it's going to take time for them to change that view. But as we move to a society where people are more engaged in information systems, I think they're going to expect and even demand this kind of transparency and the change in the doctor-patient relationship that will come about. And similarly, doctors are not used to thinking about having their notes read by anyone other than another clinician. So it is going to be a culture change, make no mistake about that. Still, Open Notes is a very powerful idea. It's a transformative idea, and it's an idea that the Robert Wood Johnson Foundation, and I believe, is one that has the power to transform healthcare. Now, I think by the time you leave here this morning, you're going to have the same view. At least that's my hope. So while you're listening, you've already heard that you can tweet using your phone, so I'm going to give you the hashtag. It is hashtag Open Notes. Go online, get other people involved in this conversation across the country. And with that, I'm going to turn to to a video so that we can see firsthand what the doctors and patients who were involved in this have to say about it. Look at the video.
One of the biggest challenges in healthcare is getting patients to understand what they need to do to take care of their health, and then actually do it.
Open notes is very simple. Doctors' notes would be open to the patients. This is a real change.
Right now, in almost every setting, a patient goes to see a clinician, they talk, the clinician writes a note, it goes in the medical record, and the medical record goes on the shelf or into the computer. The idea of open notes is to get notes into patients' hands. So through the medium of this shared document, patients can see what their doctors are thinking and facilitate a conversation between doctors and patients.
My initial reaction was that it sounds like a good idea. My concern, though, was that it would generate more phone calls, and none of us really has time for more phone calls. But we got through that, and it's been pretty invisible to us. It's not required extra time or effort on our part. Most of the feedback from patients was very good and helpful. They came better prepared for their visits. They asked better questions. They knew their medications and their doses when they came in.
What we actually found out was that it didn't really matter where you lived, how old or young, or whether you were ill or healthy. There was just really a universal sense of excitement about it.
I check it quite frequently. Make sure that we've told the doctor everything we were supposed to and see exactly what's going on.
When I need something, I just say, Mary Ellen, look it up.
Doctors, they were very surprised by how little impact it had on them. After a year, we said, you have a right to drop out. And not one doctor dropped out. More than 90% of our patients in open notes chose to read their notes. 99% of patients said they wanted to go on with this. But even more importantly for me as a doctor, more than 80% said they felt more in charge of their health care. That's a mind-blowing result for a very simple intervention. It has enormous implications for the quality of care, for the costs of care, for outcomes, for the populace. Good morning, I'm Tom Del Banco. You've just seen me. We're going to have an exciting time today, and we're going to be honest and open, and not everything is roses, and we're going to tell the good, bad, and the ugly, and have you think with us, and hopefully turn you on to teaching us and learning with us about what this is about. I want to first to say that I'm talking on behalf of a wonderful team of people. Virtually everyone is here, actually, from Seattle, from Geisinger in rural Pennsylvania, and from Boston. You can tell us because we have dark badges. And if you want to talk with some of us at breaks, etc., if we give you a break, please feel free to do so, because my colleagues are the people who Jan and I really depended on and who really got it done. We also have to thank the Johnson Foundation. It's an amazing, amazing place. You know, it's about to have its 40th anniversary. There's probably very few people in this room who have not been touched by it, even directly, not even just indirectly. What it has done for American medicine is really incalculable. What it's done for my life as an academic physician is I wouldn't be the same person, and I wouldn't have the same life. So we are very grateful. And I still buy Band-Aids and baby powder, even though they don't own that stock anymore, they claim. The other partner we've had is the Burness Communications, the people who make this look so pretty and elegant, and who fight with us all the time, and we learn to listen periodically, and have been terrific colleagues in this venture. I can't resist on the morning before a debate, which will be part of helping us see where we go in the future. And as a person who was a Robert Wood Johnson Fellow on the Hill in the 70s, remembering the legislator who just recently came up for re-election and was not a very nice man to his staff. You know, there are people that don't respect those with whom they work. And he was a bear, and he woke up 2 days before his inaugural speech for the re-election campaign, and he said to his staff, kind of as usual, you know, this is the most important speech of my life. Be ready. I expect you to be up for a couple of nights getting me ready, and you've just got to write a really terrific one. And they looked at him as they usually did, and he went home happily and came to his talk with a big crowd and looked at the teleprompter and said, "Ladies and gentlemen, this is a crucial time in our country. There are those who believe in a taxation policy and a revenue-generating policy and a way of raising money that will succor the poor and the infirm and will build up infrastructure and will have people become more able to manage the daily living activities they have. And there are others who feel that the way to do that is to give the wealthy the chance to trickle down with their largesse and not tax them unduly." I have a way of bringing both parties together. There's also this vexing issue of a woman's right to her body versus the unborn fetus. There are those who feel the fetus has claim to anything in the world, no matter how he or she was conceived, and there's the woman who feels that the right to choose is the right of the parent and the doctor, and I have a way of bringing things together. And then there's this business of transparency in healthcare. Doctors, since time immemorial, for example, feel the medical record is their domain. It's theirs, it's for their memory, for their colleagues, for payers, for insurers, and they own it, they take pride in it, they do it well, and then their patients, on the other hand, who are beginning to say, it's really mine, it's my body, I should have it, I should write in it, I should do it, I should approve it, I should check. I have a way of bringing everyone together. And then the teleprompter went on to the next thing, and it said, "Okay, USOB, now you're on your own." It seems like the right segue into what we're doing today. We've already explained, Risa's explained that SOB is a complicated word, and we will elaborate on that. I'm going to run very, very quickly through some of our results just to show you real numbers. And then I'm going to be joined by 3 terrific people. One, a patient who will talk mainly about patienthood, but is a distinguished professor of law, was a civil rights lawyer. He's a playwright, he's a novelist, he writes serious books, and he's a family therapist. We call him a polymath. He's been the dean of the law school, he's been a professor at Harvard, Michael Meltzner, and we're thrilled that he's here. Rick, you already met. Rick Martin is a real doctor. He was born in Scranton, he lives in Scranton. He's been a doctor there for 30 years. He takes care of 3,000 patients. If you ask someone in Boston to take care of 3,000 patients, they would ask you, what are you smoking? But people at Geisinger do it without breathing hard on occasion. He takes care of people who are 2 days old, and he has 5 patients who are over 100 years old. So he's going to talk a little bit about his experience. And then my invaluable and treasured partner of 22 years in this kind of work, when we began trying to see through the patient's eyes, Jan Walker, will talk about some of the implications and inferences that I won't dwell on, both from our data and from the many anecdotes we've had from both patients and doctors. And then we'll shut up and we'll turn it over to 2 very interesting panels that will follow us, bringing different perspectives. I have no idea how to do this. So let's talk very quickly about what we've learned. I really am on my own. Button on the right. Okay. Okay, what did we do? We approached about 19,000 patients, and really 13,000 patients who had at least one visit during a year. And they were the patients of 105 voluntary primary care physicians whom we should thank. We need to thank those doctors who volunteered to work with us. They took a chance, and we need to thank their patients because none of them really knew how things would come out. And as you've heard, we were in 3 very different settings, and we spent 12 months of doing something very simple. After the patient saw the doctor signed the note. This was through a secure patient portal. And the patient got an email saying, Dr. Delbanco has signed the note. He invites you to look at it. And then 2 weeks again before they came back to see me, they got another note saying, we invite you to review the former notes before you come to see the doctor. That's all we did. The other person I haven't mentioned yet, Steve Downs, who really was our full partner at the Johnson Foundation, couldn't be here today, and is an extraordinary young man, made us keep it simple. We didn't educate, we didn't teach, we didn't cajole, we just flicked the switch. And that's what we did. And we asked 3 very simple, overarching research questions. Does Open Notes help patients become more engaged in their care? A real conundrum in medicine. Glenn Steele, who runs Geisinger, basically put these questions to us when we visited him. He said, we've been marvelous. President Obama talks about us. Everyone raves about all the things we do to patients. We have no idea how to involve them actively in what we do. And this is the best chance we've had since I've been here. He also said, if you kill my doctors, you're out of here. That was basically, he was a surgeon. That was the basic way that he approached it. And those were the questions we asked. And the bottom line question is, what would happen after a year? Who would want to go on? Who would want to quit? So patients liked it. That's the first thing we've learned. A lot of them read their notes. We didn't know how many would, but 9 out of 10 patients read their notes. At Geisinger, 87% of patients read every one of their notes. And they reported to us really important clinical benefits, benefits that mean things to them and to their caregivers. They felt more in control of their care. They understood their health and medical conditions better. They were better prepared for visits. And to me, most excitingly, they said they were taking their medicines better. 70% of patients said they were taking medicines better. Now, measuring adherence to medicines is an age-old problem in medicine. We're terrible at it. Patients exaggerate, doctors exaggerate, everybody exaggerates. And we also are terrible at getting people to take more medicines, convincing them. If this were a 5-fold exaggeration, and it was a 15% increase in medication adherence, we would apply for the Nobel Prize, because it is that hard to change people's views of this. And we think this is a very real thing because we've done focus groups afterwards. We've done a lot of interviews. We have a lot of anecdotes, very concrete anecdotes of how patients changed the way they looked at medicines, took them and addressed them. And we're terribly excited about that. They also weren't scared, and they weren't confused, and they weren't offended by what they read. 80% of the doctors who turned us down said, we're going to scare the hell out of our patients. 1 to 8% of the patients were bothered by the notes. And many of them, I think, learned not to read them, or didn't read them. Doctors, on the other hand, were not creamed as they were afraid it would happen. Very few noticed longer visits or more time addressing questions. We measured email traffic for a year before and a year after, and there was absolutely no change in the aggregate. The biggest question I was asked going down the halls of our hospital is, are you sure the computer's working? We don't have time now to go into why, but it's a fascinating phenomenon if you think about it. We think patients are much smarter and much more resourceful, actually, than we give them credit for. We think they're much too afraid to bother the doctors, and that's an interesting discussion. And we think also probably that for every patient who bothered the doctor more or took more of his or her time, Another one took less time, so that it was a wash. But there was this very striking phenomenon that it was as if there was a calm little lake going on and the doctors were not bothered. They changed the way they wrote their notes. We don't know much detail about that. We didn't read each note. My guess is they wrote better notes. I wrote better notes. They were more educational. They didn't take me more time. But instead of saying, take penicillin, I would say, take penicillin because, and then have another sentence. And there would be more of an educator, which after all is the derivation of my name as a doctor. Some will have hidden things, some will have avoided things, but my guess is that this kind of transparency, this kind of consciousness of who your audience is, makes a big difference. And many doctors in their anecdotes said they were closer to their patients, that they felt safer with their patients, that they had another set of eyes watching them. We think of this as a new medicine. I can't help it, I am a doctor. And that it's a new medicine that I hope will become a new standard of care. And I'm in a hurry also, as Risa is. I'm old, and I'm not going to be doing this forever, and I'm impatient, and I want to see it happen quickly and not for us to ponder too long. But this medicine is designed, as are really all medicines, to help the vast majority of patients and to help those who care for them. I can't emphasize that enough. This isn't just a patient thing. I think it will make the life of the doctor or the nurse or the other caregivers in the family or whoever a much richer and a better life when they get used to it. There will be contraindications to this medicine. There are with every medicine. There will be some patients who shouldn't read their notes. They'll figure it out. Their caregivers will figure it out with them, and they'll agree to do that. People will learn how to use this new medicine widely, wisely, and well. It'll take a little time. It'll be a learning curve, but I'm very bullish on that. We've had help from the Johnson Foundation, and let me tell you again the bottom line. 99% of our patients wanted to go on, even those who didn't read their notes. I've never heard of a study in my life in which you get a 99% figure from a survey of 6,000 people who returned surveys to us. 85%, as Risa mentioned, said it would be important in choosing a future doctor or caregiver. And not one doctor stopped after a year when we offered them that option because they had signed an IRB approval to go for 1 year and no longer. They didn't all love it. Some of them would have been happy to stop. But I think what happened is they looked at their patients, they looked at themselves and says, this is a one-way track, we can't turn back. And not one stopped. Michael, talk to us as a patient. Yep.
I don't do PowerPoint, and as a patient, I can be disorganized. I come at this from a variety of perspectives. As a law teacher and a lawyer, my first reaction was, well, what would happen if lawyers and clients had to do this? And I had dinner last night with a big-time ethics professor, and he said he's going to write a law review article about that. So that was really interesting. And I come at this as a family therapist who loathed writing progress notes, a requirement after every session. And so often made use of the fact that I write illegibly. And nobody, even myself, can read my particular notes. So I feel very blessed by the computer world and the ability to not only read my doctor's notes, but to have a feeling that this can be generalized. So the general idea of sharing notes might be controversial in the medical world. From what you heard, it certainly was before this wonderful study. But from the vantage point of this patient, at least, the idea is so obviously advisable that it seems unnecessary to me to squander much time debating it. Once you've had the opportunity to use Open Notes, it's difficult to imagine going to a new physician who declines to participate. And in fact, the next question you have is, why aren't specialists involved in this? Why is it just PCPs? It's hard to believe, I know, but apparently some doctors resist change, but I guess that just proves they're as human as lawyers. In the old days in my trade, when a change in court rules was suggested, the bar rose as one and argued, oh no, we can't do that. It didn't have anything to do with whether the new rules were necessary or better. It had to do with the fact that existing practitioners had to learn to do it in a different way. But these days, there's so much change, it's so relentless, that you rarely hear such objections anymore. Attention is really directed to implementation. That's where the name of the game is, and that's where I think we are with respect to Open Notes. And so I have, rather than telling you my own personal stories, because we only have a morning, I'm going to try and make 3 points about implementation. Because I'm an academic, the first step that occurs to me is moving to train doctors to write to patients in an intelligible way without feeling that they're being condescending or inaccurate. And as Winnicott's famous phrase about mothers really applies here, we don't need perfection, we need good enough communication. But still, unless the bar is set high in medical school, unless medical educators really focus on this problem, doctors, I believe, are still going to write to patients in unnecessarily obscure ways, or they're going to write pure gibberish. And I don't know whether this particular study, as wonderful as it is, really got into the language issue, and that's something that I hope is discussed later on. In law, our standard for unintelligibility is the Internal Revenue Code. And in a course I once taught called Writing About Law, I gave a section of the code that dealt with charitable deductions to my students. And I said, write a description of what this section means for your Aunt Sadie, unless your Aunt Sadie is a tenured linguistics professor. And the first set of writings that came back were truly a disaster. And so I gave them I said, do it again, and I gave them an example, a model of someone who had described the law of habeas corpus to common readers, to lay people. Not an easy thing to do. And their second cut was much better. But I wasn't satisfied, and so I, even though they threatened to lynch me, required them to do it again, and it was actually something one could understand. The point here is that how we explain things is learned behavior, and we can learn to do it for different audiences and in a way that they can understand it. I do think medical educators have to be brought into this loop. Second, in a recent dialogue, Sunday dialogue in the New York Times, which some of you I'm sure have seen, a letter writer suggested that doctors and patients don't argue enough over serious decisions. She claimed there was too much deference on both sides, and at times a direct challenge was necessary. One of the respondents agreed about the need for better communication, but disliked the notion of argument and said what we needed was a good conversation. He wanted doctors to talk more about pros and cons and patients to talk more about fears. Other letter writers addressed attention to the unequal power relationship and knowledge relationship between doctors and patients, and they urged doctors to do more informing and less influencing. Now, regardless of how you approach this nest of issues, embracing open notes in the actual presence of a patient is going to help. Write a few lines, I would say, to a doctor on your computer. Move the screen over so that the patient can see it. Show it to the patient. Say any questions, any corrections, any additions. If some mega issue surfaces, push the screen away and have your conversation. It's then a conversation that is grounded. It's grounded in specifics. And having been there as a patient, I can tell you amnesia is often with us. And so this is a way far superior to email, tweets, telephones, texting, in communicating with a patient. Of course, this kind of process will not work for all patients, but then nothing will work for all patients. What concerns me most, and this is my third point, is making open notes accessible to the populations that can't access it. It's primarily computer driven, and unless we're going to have another sad example of a two-tiered medical system, supporters and promoters of open notes have to make great strides, and they have to do it soon. Otherwise, it will get a reputation to assure that the poor and the old and the techno-peasant like me, the disabled, and indeed any group that can't or has difficulty accessing a doctor's notes can get the information. It's easy to point this out. It's easy to point this out and then move on to another topic. What's hard is actually doing this. And what it requires is innovation. It requires new devices. It requires remedies targeted to particular groups, alternate means of communication, and what all that means is money. And so I think everything we're going to talk about today, or in the study and my own experience with it, is absolutely marvelous. But for me, it's phase one. And phase two requires commitment from a lot of stakeholders. And it's going to require innovation, and innovation requires investment. It's the next frontier, and I just want to urge the talented and committed and resourceful team that's created the best means of leveling the playing field that I've experienced in my lifetime in healthcare, devote itself to these kinds of issues. Thank you.
Good morning. Thank you all for coming this morning. This has been a unique experience for myself and several of my practice partners to participate in this sort of an experiment. But to me, it's sort of intuitive. Notes are about patients. They're about the conversations that we have in exam rooms. And in my mind, patients should be entitled to see their notes and to discuss their notes. So we need to get over the hurdle. I think I was very fortunate in the early part of my career to meet and befriend a physician who was a third generation in his practice, a practice that was founded by his grandfather in the late 1800s. And this gentleman frequently commented to me that the way that he provided care was really no different than his grandfather did almost 100 years before. Granted, we had different treatments, we had different medications, but the process of delivering the care, the process of providing the care was essentially unchanged. And that resonated with me throughout my career. It taught me to keep my eyes and ears and mind open to new and innovative ways that we could provide care that we might be able to do a better job with our patients. So to that end, during the course of my career and with my practice partners, they tend to get a little annoyed with me from time to time, wondering what's next, what's Martin up to now. About 12 years ago, we were fortunate enough to participate in a program that was sponsored by the Institute for Healthcare Improvement that was called Idealized Design for Clinical Office Practice. And this was a 3-year study that 30 practices participated in, literally from around the world, where we tried to find some efficiencies and consistencies around the way that medical care was delivered in the office setting. And we did learn some things that we still use in our practice from this. But more importantly, being part of this program instilled a culture of innovation and a culture of change in our practice, so that the nurses and the front desk staff and my partners, who have been fairly loyal and collaborative through the years, understand that change is okay, and we work toward that. So when this came about, it was really nothing new or different for our practice. It was just something else to try. Personally, as you saw in the video, my concern was workflow. As Risa mentioned, is this going to mean more phone calls? Our phone staff is already overwhelmed. We have a busy practice. Our doctors don't really have time for more phone calls. We have 15 or 20 minutes with appointments. And I'm happy to say that none of that really came to be. So we were very happy with the outcome that you saw. With regard to your comments about language, it's not only how we write to our patients, but how we speak to our patients. I find myself as a family doctor many times being the interpreter for my hospitalized patients, people that are in intensive care units, having surgery. Our specialists are way up here, and patients look to us as their primary care physicians to let them know what's really going on. My wife has a very close friend whose husband was recently diagnosed with a malignancy, and this friend calls her several times a week over the past month or so. Can you ask your husband this? Can you ask your husband that? I'm not his physician, but the situation they're in is the surgeon tells him one thing, the oncologist tells him something else, the radiation therapist gives his view, and there's nobody there to get their arms around it and bring it all together. They can sit down and talk about it. And to have a conversation, let alone be able to see the notes and be able to recall much of what was on in these visits would be a tremendous help for these folks. So, in my opinion, this is a good thing, and we need to figure out a way to spread this across the nation, let alone across our health systems. Not all perfect, a few lessons learned. We have an instance in our electronic health record whereby people with certain minimally abnormal lab values, a diagnosis is auto-populated regarding kidney disease, chronic kidney disease, in people who don't really have clinical kidney disease. And they see this in the notes. It's there. We've not necessarily addressed it because in our minds they don't have kidney disease. That's probably been one of the things that's been brought up to us most often. One of my partners had a gentleman who disliked the diagnosis of morbid obesity in his chart and asked that it be removed. He asked for my help as his medical director. What should we do about this? Well, we can't alter the medical record. If there's a diagnosis, it's there. That prompted a conversation that I became part of with this patient. Now, the fact of the matter, this man weighed about 360 pounds, so it was a valid diagnosis. I'm happy to say that the last I heard, his weight was below 300 pounds in less than a year as a result of the conversation and the discussion. So patient engagement and empowerment, it's there. Maybe not the way we intended it, but and this is without bariatric surgery, without medication. This is with lifestyle changes, so that's a good thing. I recently had a gentleman who raised a question about a diagnosis of COPD, and we talked about the abbreviations. This gentleman has been hospitalized several times over the last few years with respiratory issues. He's been on inhaled medications, he's been on antibiotics, he's been on oxygen, and yet he didn't quite understand what the issue of COPD was in his medical record. So that was a message to me that I probably didn't do a good enough job educating him and explaining to him the significance of his diagnosis. So still lessons to be learned, but from the standpoint of a practicing primary care physician, I think this is a good thing, and I think that we need to get over the hurdle nationally and learn how to develop this. Thank you.
So we've heard from a participating patient, a participating doctor. What I'd like to do is describe a few of the themes in the comments we heard from doctors, patients in this study and beyond, and some of the data, and where I think some of the ripple effects of this might be in our healthcare system. First, we heard a lot of comments from patients about, I read my note, and you know what? The doctor really listens to me. And furthermore, I read the note, and the doctor isn't hiding anything from me when we're talking in the appointment. And I think this has implications for trust between patients and their clinicians. And we all know that malpractice cases often arise out of imperfect communication between doctors and patients. Might this have an effect on malpractice? We've heard from patients about things, I wish this had been available when something was diagnosed and my doctor forgot to tell me and the treatment was delayed. Or I read my note and I realized the doctor forgot to order a test that we talked about and was in the note, and I reminded the doctor to order it. So might this have implications for patient safety as we go forward? We've heard from doctors about, following up on Rick's comments, I'm so busy, I don't have time to write notes that can really educate my patients. I just don't have time. So I have to put on my nursing cap for a minute here and think, this is an opportunity for nursing and other health professionals. We are all educators, we're all patient advocates. That they have a role here, I think. And this is all about teaming and making the patient part of the healthcare team. This is a huge part of patient-centered medical homes that are proliferating now, that we're testing. Having this information available to the patient is undoubtedly going to make them a better team member. And I think that, part of our vision is that someday maybe even the clinicians and the patients will write these notes together. Now that's teamwork. We've had patients who've said things to doctors, I read my note, I understand it, I've done everything we talked about, I feel fine, and you know what? I don't think I need this next appointment in 2 weeks, let's postpone it. This is just one example, but I think this could conceivably have some effects on cost containment as we go forward. Let's find out. We've also had comments from patients who didn't participate in the study, and oh gosh, this is such a great idea, but my doctor doesn't have electronic medical records. This is not dependent on technology. Technology will make it go in the long term, but even for doctors with paper who are still doing paper records, send the patient a copy in the mail. The idea is to get it into patients' hands. And I think as health professionals, all of us have this nagging question in our minds, should patients really see everything in the record? We have some ideas about this, but I think this is an open question. And I think that as we go forward, the practical details of this can get worked out. I think it is a question. And finally, between 20 and 40% of the patients in this study said they shared notes with other people. Most often it was a family member or relative, but they made the decision. The note between the doctor and the patient, that conversation is still confidential, but now the patient controls whether it's private, whether they want to share this note with others. They share it with their caregivers, who we've heard say that this is enormously helpful. They may share it with other
clinicians, getting an informal second opinion. They may share it with their attorneys. They may post it on Facebook. This all makes us very nervous, but I think we have to get over it. I think we just have to get over it. So this is a really simple intervention, but I think it's multi-layered, and there are lots of things that we can work out as we go forward.
Thanks, folks. I mean, we're excited by this. We're going to do some outrageous things. We have a locked psychiatric ward in our hospital. These psychiatrists are willing to have the patients there read the attending notes every day. We have a pain unit with multiple addicted people in it. They want to give open notes to these patients. We're going to take head-on the issues that people feel are difficult. MD Anderson, I don't know, I've seen Tom Feely. Tom is here. MD Anderson, 30,000 new cancer patients a year. Every one of the notes is open to their patients. And the place has not come down. It's hard to bring down that place. It's enormous if you ever look at it. But we're on a good adventure. How about us with a couple of questions, and then we'll move on to the next panel. And use the mic, please. Put up your hands. Challenge us. We like to debate. Dave? Tell us who you are.
Dave DeBronkart, one of the participants in the study. And another participant from our hospital on Twitter is saying that he compared what's in the notes that he can read with other things that he found, and he found that his providers were having back-channel conversations that were not in the record, and he's concerned about whether this is interfering with the integrity of the process. What do you think about that? I mentioned to him that a proportion of doctors said they had altered what they recorded in the notes.
You know, the sunshine laws in this city changed the way laws were written, laws were implemented, regulations were written. And the usual backroom chatter, which actually kept our country going pretty well for a while, I think, was made illegal. Everything was going to become transparent. I think, as everything in the world, that things are never black and they're never white, they're gray. And I think transparency has its pluses and its minuses. I'm not sure I want my gifts as a doctor to be exposed to everyone on Facebook. There might be some who take umbrage with what I say. And it might be easier not to have that happen. But it's going to happen. There will be back chatter all the time. The patients will back chatter. The doctors will back chatter. Hopefully they will get together over what's important and make it work. But this is not a simple issue. What we're doing is not simple. One more? Yeah. Josh. Tell people who you are.
Josh Seidman, Evolent Health. I was wondering if you might give some examples of what happened when the patients who were reading notes were not English speakers, or if they were not, or they were not literate, and any attempts that you made in particular to address the questions that were raised about how to make those understandable.
Let me answer that obliquely. One of our hypotheses that was decidedly proven to be wrong was that the people who would love open notes are the people in this room, the yuppies, the highly educated. Everyone's looking at their Twitter or their whatever it is right now and looking a little guilty about it, I hope. Those were the people who would love this. What we found, to our astonishment, although in retrospect we should not have been astonished, is that those with less than a high school education and the elderly were at least as excited about open notes as the yuppies. Fascinating for us, and we have many reasons why we think that might have been the case. Adult literacy, we always ignore it, and we don't do well with it. Language in this wonderful melting pot of a country is always an issue, but the technologies are really going to help with that. There's going to be a day very soon when you push a button that says 6th grade, and another button says 8th grade, another button says 10th grade, and another button says Seidman. There will be all kinds of levels, and languages can be already translated instantaneously. Henry Feldman, who's our computer Nick and who's here, I mean, the gadgets that he's going to do, we're going to put cursor over SOB, and it will say dyspnea, or it will say SOB, or it will say shortness of breath. People will do that. That's why they aren't calling us already. They've learned all of that. This is the Model T stages of this evolution, I think. And the sky's the limit. The portal we're designing at our hospital, the next generation, will dance for patients. It will educate them. It will upload their data. They will be writing the notes with us, I hope. They will be signing the notes with us. They will be modifying our notes. They will become contracts. We have a great fantasy life, and all of this can happen in the future. We think this is where we're going. We're just starting. And we should also stop.
One more point. But in the meantime, patients have families, they have friends, they have a network. They'll manage if they need something translated or explained.
Let me introduce two Christines while the rest of you leave. Christine Lane will moderate the next session. Christine Lane is a doctor. She is the youngest female editor, I think historically, of one of the great journals. She's the editor of the Annals of Internal Medicine. For my money, it's become the most exciting medical journal. I actually want to read virtually every article in that, as opposed to some of the more famous ones and the glossier ones that I have to work hard sometimes at understanding. She calls herself, interestingly enough, a medical journalist, even though she's a primary care physician. And she has been generous enough to publish 3 papers from us as a series, and we've asked her to moderate the next session. Christine Bechtel, whom I have not met, but whom I have talked to on the phone, and comes across, as far as I can see, as somewhat of a force of nature, is the vice president of the National Partnership for Women and Families. She's been around. She's worked with the AARP. She's worked on the Hill. She's worked with the eHealth Initiative. I think she probably gives the people in ONC a hard time on occasion as she thinks about this wonderful word, meaningful use. And she will take us on quite a trip, I suspect, when she steps up for the 3rd panel. Yes? Yeah.
It's a thrill to be here, and welcome to panel 2. It's the view from the healthcare leaders. So given the title, you're not going to be surprised that we're going to have healthcare leaders. The panelists include their backgrounds and their accomplishments are in the program, so I'll just briefly introduce them. First on the panel is Dr. Kevin Tabb. Dr. Tabb is president and CEO of the Beth Israel Deaconess Medical Center in Boston. Since taking this position in 2011, Dr. Tabb's focus has been on strengthening the medical center's network and optimizing its management structure, not only to optimize business goals, but also with a keen desire towards optimizing patient care. Next on the panel is Eileen Whalen. Ms. Whaling is leading in the nursing profession and the current executive director of Harborview Medical Center in Seattle. This position gives her a wealth of experience and expertise with the particular challenges of caring for vulnerable populations. And finally, Dr. Mike Zeidel joins us. Dr. Zeidel is the chair of the Department of Medicine at Beth Israel Deaconess Medical Center. As department chair, Dr. Zeidel must deal daily with the usual challenges of that position, keeping faculty happy and productive, overseeing training and research programs, et cetera. But Dr. Zeidel has also been described to me as a department chair that cares an awful lot about quality of care. So those are our panelists. Just a few words from me before we go into their topics. I guess it was almost 2 years ago when Tom submitted the first paper about open notes to Annals of Internal Medicine. It was a commentary describing this project, this experiment that they would be doing. And we sent it for review, and then we discussed it at one of our manuscript meetings, and my colleagues thought I was crazy for even bringing it to the meeting. And I said, this is really interesting. And they said, but this isn't a study. It's going to be quasi-experimental. And they're not looking at outcomes. They're just asking people what they think. And I said, no, I think we want to publish this. So the first piece was a short commentary. And then we had the baseline data, and my colleagues were a little bit more excited about that, although we did put Jan and Tom through the ropes with getting it into a form that our readers would pay attention to it. And then by the time we got the final study, which was reporting the results, complete about face among my colleagues. Everybody was like, "Oh, good, we got the final paper." So I think that it was some firsts. It was one of the first times as editor that I sort of went against my really trusted colleagues' opinions about whether we should publish something or not. It also provided the first time that we ever had an editorial written by a participant who was in the study. So Michael Meltzer wrote one of the editorials. We had two editorials. Dr. Carolyn Goldzweig, who's also in the audience from the UCLA VA, wrote the physician perspective editorial. And it really, I want to thank RWJ, Tom, all the people who participated in the studies, because our web traffic and our media hits have gone way up because we published this. So with that, I'm going to start with our panel. Okay.
Yeah. Great. Well, it's great to be here today. You know, in many ways, I think I want to first of all echo what Risa said, that this has been a long time coming from my perspective. I'm new in my role as a hospital CEO, and I'm going to talk a little bit about why open notes should be of interest to us as hospital CEOs. But before I get to that, while I'm new in my role as a hospital CEO, I've been involved in healthcare IT for a very, very long time. And you can say a lot about healthcare IT, but I think what everybody can agree is that in many ways, the hype has exceeded the reality. This feels very different. And I think it's fascinating that a project like Open Notes is one that feels so different in the realm of healthcare IT, because so often we're fascinated with the latest expensive device, or with a very difficult and expensive and proprietary piece of software. That's not what this is about at all. This is something that anybody can use, any system that you have. And so I think it has the potential to make a pretty significant change. I said again that I've been in my present role for about a year. Actually, it's been exactly a year this week. And on my very first day, in the midst of 100 different things happening, Tom Delbanco showed up in my office to talk about Open Notes. I didn't know who Tom was. But I said, "Have a seat." And he proceeded to very quickly tell me about Open Notes. And he looked a little worried and said, "Now I just want to know sort of generally what do you think about this?" I said, "It sounds great. Let's do it." And I think Tom was a little taken aback and said, "Well, now, you know, we still need to, there's a lot that we need to understand, and we need to get this through all of the processes. I'm not sure you understand. This is Harvard. It takes time." I said, no, let's do it. And in fact, we are going to do it. We're going to roll out Open Notes to our entire institution, to all of our patients, not just physicians that are primary care physicians, but all of our specialists, not just patients that come in and see a primary care physician, but any patient that interacts with our system. And by the way, when they look at those notes, they're not just going to look at the physician note. I think sometimes we forget. A note is a complex thing. There are nursing notes. There are speech therapist notes. There are all sorts of things in there, and all of those things are important. And we're going to open all of that up to all of our patients. So, you know, I've been asked a number of times why, as a hospital CEO, would I be interested in having this happen? And I think that there are a couple of different reasons. I can think of three off the top of my head. First is, sort of back to what Michael said as a patient originally. This is the right thing to do. Let's start with that. I can't imagine not doing this. It very much feels like the right thing to do, and now there are data to support it. So we need to do it because it's the right thing. I think that there is also a business case to be made from my perspective. We believe we can and will differentiate ourselves in our own market by being the first and by offering something that patients actually want and that patients will actually use. And we think that that will really be a differentiator for us in what is a very crowded market for us. The third follows off of that is, long term, I actually hope that it's not a differentiator. Long term, I believe that this is going to become the standard of care. And everybody will be using this. And I just want us to get there first. So for us, this is clear that we need to do it. I'll just tell one other quick story, which is after Tom and I talked on that very first day, I did realize there was a process that we needed to go through. And so we talked about what that process would be, and we said, let's bring it to all of the department chairs. We've got a lot of department chairs. And we sat down as a group and talked about it. Tom presented the data, and there was a vigorous discussion, pros and cons. But I suggested that we take a vote. Let's see. I said, but it's not a secret ballot. Let's take a vote. Let's see, what should we do? Should we roll this out to everybody or not? There were lots of people that had lots of questions about should we, shouldn't we? And we decided, or all of the department chairs decided unanimously to do this. Now, I don't know of anything else that I've done in the last year that has been unanimous. But really, I think there was a realization that it is the right thing to do, that this is the future, and that it's time to get on board with it. So we're very excited to take that next step and to move into the future. Thank you.
Eileen? Okay.
All right. Well, good morning. Thank you very much. My name is Eileen Whalen. I am the Executive Director, CEO at Harborview, which is part of the University of Washington. And I think it's very interesting that Harvard and the University of Washington are taking such a huge leap forward and really paving some way for the future. As was thankfully, as noted in my introduction, which I appreciate the kind introduction, my background is nursing, so I approach this from a little bit of a different perspective, and maybe I could share some of that perspective with you. First of all, I want to thank Joanne Elmore. She's been an unbelievable champion for this project at Harborview, and I also had the opportunity to have a one-on-one meeting very shortly after I became the CEO at Harborview. And the force of nature, when Tom comes to your office and says, this is what we should do, it also became one of those things that I thought, you know, you're right, we should do this. And in the world of all the complex things we as CEOs have to deal with, this was one I said, oh, thank you, please, let's do it now. So I really want to thank you for your leadership in that. We made a case pretty clearly. Our philosophy is about transparency, and transparency is absolutely core to our culture and our mission at Harborview. So this was absolutely clear to us that transparency at every level, whether it's between our physicians, our staff, whether it's now with our patients with the Open Notes Project, it made great sense. The other thing we tried to do is really think about, it's not about you as a practitioner, it's not about you as a nurse in the clinic or a team member, it's about the patient. And what would you want if you were the patient? And we do have a very complex patient profile. We are the Safety Net Hospital in Seattle, but we're much more than that. We have high tertiary quaternary level services that we provide. For example, our Level 1 trauma program serves a third of the landmass of the United States. I flew in last night, and every time I come to DC, I think, my God, so many of my trauma patients have made this journey from Alaska for their acute and tertiary care for trauma. If we could take open notes, for example, into that specialty care, when we transfer these patients long distances, and we're no different than many of the communities you serve, these patients go home to Anchorage, they go to Juneau, they go to these teeny little towns in Alaska, Montana, Wyoming, Idaho, you name it. If we could take that open notes concept and let that be available to the primary care physician and the family, obviously, who's in that small community, how much better the patients in those communities would be served. I also want to comment on the multicultural aspects. We serve multicultural, as you all do. We speak over 85 languages in our primary care clinics alone. So I want to disabuse the concern that language and or homelessness is a barrier, because it's not. Because we have all developed ways for our homeless population to have access to the internet, whether it's in my hospital, whether it's in the community, whether it's in the public library, whether it's the mobile phones we give them to make sure they make their appointment. We have figured out a way to make the access to open notes in the future available to the homeless, as well as those people who don't speak English. I also agree there's definitely a financial case, a business case to be made for this. And I have no problem working forward with that business case in my organization because it is the right thing for patients. I guess I'd like to just share a couple of stories which probably resonate with each one of you. I was born and raised in this city, Washington, D.C., not the other Washington. I'm one of 10 children. I am the only medical person in those 10 children. And like many of you who have commented earlier, you get those phone calls from so-and-so, so-and-so's mother-in-law has been admitted here or there. I'm in the process right now of managing a brother who had stage 4 cancer being treated, lung cancer being treated here in the city. If it wasn't for the fact that his oncologist is so willing to email me constantly so I could be the spokesperson to the other 9 or 10 plus, this poor oncologist would just be inundated with my family members trying to manage his care. If open notes was available in this particular situation, her life would be so much easier than having my 9 brothers and sisters barrage her on a daily basis with emails about my brother's care. It's no different. I managed the same with my elderly parents when they both died. It is just something that today, I think back on some of the clinical things that we did years ago. When somebody broke a leg, we hung them in traction and put them in the hospital for 6 weeks. My God, that's criminal today. We would never do something like that. This is no different. It really will become so commonplace in our future as we go forward because it's really what our patients are demanding, it's what we as educated people are demanding, and it's what makes great sense.
Dr. Zeidel?
So I'm Mark Zeidel. I'm chair of medicine at Beth Israel Deaconess and a professor at Harvard Medical School. I've been privileged to lead actually 2 departments of medicine, one at Pittsburgh and the one at our department at Beth Israel Deaconess. And I've also been very privileged to be able to push the quality agenda and quality improvement into academic departments of medicine around the country through working through national organizations. And watching the quality movement move forward across the country, I was struck at the beginning that organizations that were not academic were leading and that the academic organizations were lagging. And I think that we can do this differently. This is something that academic institutions ought to pick up right away, and it's something that can be brought forward through academic institutions as well as community-based sites. As Tom has pointed out, this is a new therapeutic. Okay, we can call it a new drug or we can call it a new device. It has, I think, wide application to large numbers of patients and will benefit them enormously. There are some patients who won't benefit and who probably we need to figure out which ones. Because it's a new therapeutic, there are new questions, huge new questions that need to be answered. Which patients will benefit and which will not? How do we pick which patients will benefit? What are the outcomes? How do we optimize the care? Using the quality improvement model, how do we standardize the notes in such a way that they are maximally informative? And then in the educational realm, how do we train our residents, for that matter, how do we train our doctors to write notes in such a way that they are optimally informative, most likely to improve care? The other thing that this does as this goes forward is it has a very powerful impact on electronic medical records, because although this works with every electronic medical record, many of the electronic medical records that are being bought and sold fragment the narrative of the doctor and try to force the doctor to write notes that put numbers into boxes and diagnoses into boxes and don't allow for a coherent description of the patient's problem. If we're sharing the note with patients, they're not going to accept it. They're going to want notes that are narrative in format that describe what's going on and can go forward. We need to understand how to communicate more effectively with the patients. That's clear. This does this in a very strong way, but there are ways to make it better. So what this means is that outcomes researchers across the country, in academic settings and in community-based settings, now have a very new set of questions that are very important. Educators have a new mandate. How do you train people to do this in a sensible fashion and move things forward? I think we should be pushing this forward in the academic side so these questions get answered at the same time that we do it. And that these innovations, this innovation as it goes forward, will improve care, and then we'll get really good at understanding how to make it improve care with as much efficacy as possible. So my view of it is that we need to push this very hard in the community settings, and many community settings will try it. At the same time, it needs to be studied as we go forward. We don't stop and study it. We do it, and then we study what occurs, because we didn't spend a huge amount of time figuring out if penicillin was going to be good to treat pneumonia. We used it, and then we learned more about it as we went along because it was so clear that it was efficacious. So that's where I think this is heading, and I look forward to efforts at the national level to move this out. One other comment, people have mentioned specialty care. Many specialists, I'm a nephrologist, take care of patients with incredibly complex chronic diseases. I can imagine dialysis patients looking at their record with this in mind. I can see vast improvements in care that have already occurred in patients like those on peritoneal dialysis as they've been better educated about how to care for their catheters. If patients with chronic diseases who are cared for by specialists have access to this kind of information, again and again and again, repeating and understanding the elements, they will do far better. Imagine for the moment the chronic renal failure patient who shows up, whose creatinine is high but much higher than what we were hearing about before, and they now have to modify their diet. They have to go on to ACE inhibitors. They have to reduce their phosphate intake. They have to be concerned about their calcium and their sodium intake. And we tell them all of that in a 45-minute visit, not 20 minutes, 45 minutes. They haven't got a ghost of a chance of understanding that. But if it's all written down, and the nurse who also counsels them can write things down and put them into a record they can read, we're going to be much more effective at getting them on top of their disease and under control. And I can tell you that the dialysis patient who understands their disease and takes an active role in their care lives much longer than the dialysis patient who doesn't. So this is wide open for specialty care. Every specialty needs to study how to do this effectively and what populations to use it with, probably almost all, and how to do it with maximal efficacy.
Okay. So we have a few minutes for questions, and Dr. Zeidel answered my first question before I asked it, which was about should there be a research agenda going forward. We heard that we have a lot of very promising evidence, but it sounds like just like penicillin. I think that was an excellent analogy. I have one question for the panel, and then we'll move to questions for the audience. So in the editorial that appeared last week when we published Open Notes in Annals of Internal Medicine, Dr. Goldzweig wrote, "The strong message from patients is that it makes them better patients." So if this proves true, and Open Notes does prove to make patients better patients, should reading the notes be required for all patients as a condition of continuing care?
I don't think, well, again, we have VA colleagues here, and I spent a lot of time caring for veterans, and it was a real privilege. I used to try to require my patients to buy a scale, because I was taking care of kidney disease patients, and a blood pressure cuff. And many of these patients would come to the VA to get their Tylenol filled, because at the time it was the only place where you could get the medicines for free. They would buy the scale, and they would buy the blood pressure cuff, and they would learn to take their blood pressure, and they would do it. I don't think you can require anything, but what you can do is encourage it vigorously. And if you encourage it vigorously, the vast majority of patients will do it, and when they do it, they will benefit from it. And I think that's the way you can make it an expectation in the practice. Did you read the note, as I used to, and did you bring in your blood pressure measurements? Did you weigh yourself? But not everyone will do it.
And let me just follow on that. I think that, as been mentioned by a number of different panelists, we should think of open notes as a medication, as an intervention, as no different than any other intervention that we presently have in our arsenal. And so the question shouldn't be different for open notes than anything else. We don't typically fire our patients if they don't take a certain type of medication, if they refuse or whatever. We encourage, we show, we don't, and I wouldn't think of open notes as any different, for better or for worse.
So, Ms. Whalen, one related thing. So in the manuscript, in the report of the study, there were some differences between the sites. So 84% of the patients at Beth Israel, 92% at Geisinger, and only 47% at Harborview access their notes at least one time. And so do healthcare institutions and providers have a responsibility to promote the use of this among people that may not have a natural proclivity to seek information and become engaged in their care? So if people get that email that Tom described and don't take advantage of their notes, should the doctor at the next visit maybe read through the note with the patient, or should we be doing something, or should it really be left up to the patient whether to engage in this activity?
Great question. I agree with the comments made before. Mandating that really will get us nowhere. You can talk to a patient till the cows come home about how important it is for them to lose weight, and they can't do that change in lifestyle. I do think that the way to really work this through is to make it valuable for the patient. So at that next visit, sit down in the medical home concept, of which we're all trying to implement at the same time, with all the team members using that note and really showing the patient and the patient family member the value. And as you go through that next visit, here's teaching the family member, here's how you can access your mom's lab data, or here's how you can access the result of XYZ, whatever intervention we did, and make it something real for the patient, and really work through those barriers. I do think that we have to really think generationally. Today, we all write notes. Today, I shouldn't say we, many of us in the audience were trained that if you write something down, it sticks in your brain. That's not the way my son works. That's not the way the 20-somethings today work. If he had to write a check for a bill, he wouldn't know how to exist. Everything is electronic. So I think really bringing the generational issues in and really expanding on the generational importance and realizing with our own culture and our own clinics and our own physicians, that's an important step going forward, how we can really take that to the next level.
Questions from the audience? And I see Tom has one, or a comment, more likely.
I've learned always to listen hard to Christine Lane. I learned that a long time ago, and I'm not so sure we shouldn't make it pretty tough on patients who don't. Now, we have some examples. Our MS clinic at our hospital actually will not take care of patients unless they sign up for our patient portal. It's part of the terms of engagement. And they communicate primarily with the nurses there through that portal in many ways. That's part of the agreement. I've long felt that with my patients, we really have an agreement and a contract. And alcoholism is an interesting example. One of the things you learn as a doctor, if you're managing people who are having trouble with alcohol, is that if you're a good doctor with those patients, you will lose some of those patients. You will make it so uncomfortable for them to keep drinking that they will say, well, I'd rather go to Zidell because he's a nice guy. But they will also tell you in AA that once you've done that for that patient's never going to be the same again, and will view his drinking or her drinking habits differently and maybe do better in the long run. You take some chances. So I actually am rather intrigued by your question, and I think there might be a day where, as we make this new contract with patients through this transparency, through us perhaps both contributing, co-signing the note, co-generating the note, and then judging our quality on how I as a doctor and how you as a patient do over the year, and we could even have a metric for that that Mark could give me a grade on and that I could grade my patients on. I think that's what you're going to see happening in the future over time. So I don't think I'll be so gentle about it.
Okay, we have time for one more question or comment.
Okay, Pam Mitchell from the University of Washington. It's kind of a combination of question and comment. Bravo and brava to all of you. I have been part of a group through the Institute of Medicine, Best Practices Collaborative, around values and principles in team-based care. And one of the things that struck us was how few tools are available for patients and their families to become engaged and to become the center of their care. This is absolutely fantastic. Then the second part of the comment is a challenge to all of you to engage within the academic centers, the interprofessional movement that has on the ascendance again. The deans of all of the health profession schools at the University of Washington are committed to a new resurgence of this over the next year around curriculum and learning to communicate with our patients and write notes together. I think should be the very first thing that we do. So we'll be talking more, Elaine and Joanne.
And I think, Dr.
Thank you. Really quickly, I was intrigued, Eileen Whelan, about your comment on mobile technology and using smartphones or other technology like that, because we know that those are often more accessible to people across a wide range of economic situations. So could you just comment more on what experience you had at Harborview?
Sure. Not specific to Open Notes, but we have been involved with many different trials providing our patients with cell phones and or opportunities, and really to decrease our no-show rate for clinic appointments, to really send those reminders. Some of this has been grant funded, some of it we've taken on ourselves. But we found that it has decreased, it has really involved our patients in their care, it has decreased the no-shows, it has increased some of those behavioral things that we're trying to get patients to do. It's been really very helpful. We also have a very extended program in our community with respite, with various different, as in most safety net hospitals, care that we provide is not always in the walls of the hospital. We're heavily into the community. So these mobile devices have been incredibly helpful for us to keep patients in the community, out of the emergency departments, which is an incredibly important part of all of our work, and really reduce the readmissions for unnecessary things. So.
Okay, and Tom may listen to me. I also listened to him, and he told me that we're finished. Actually, he didn't tell me directly, though. He sent somebody up with a note for me. So thank you for your attention, and thank you to all the panelists. This is wonderful.
You guys hear me okay? No. I think so. All right, so apparently now we're good to go. Good morning. How are you?
So I am very excited about this panel. This panel is about implementation and what can we do, when can we do it to make open notes a new standard of care. And I am joined by three distinguished individuals who bring with them the perspectives of three of the most important players in healthcare: consumers, hospitals, and of course physicians. So to my right is Dr. John Santa, and he is the director of the Health Ratings Center at Consumer Reports. And next to John is Chantal Warzala. She is a director of policy at the American Hospital Association, where she focuses primarily on health IT. And then Dr. Stephen Stack, who is an emergency room physician in Lexington, Kentucky, and also the current chair of the board for the American Medical Association, Board of Trustees, I should say. So welcome. We're excited to really talk about what does it take for the rubber to hit the road here. I think, in my own view, and I come from a consumer organization, right, nonprofit based here in DC, been around 40 years and do a lot on the delivery system to try to really make it more patient and family centered. So from my view, this notion of opening up electronic progress notes is a very simple concept that has the potential to really be a game-changing gateway to meaningful patient and family engagement, right? Something we all talk about and we all seek and pursue, but we haven't quite figured out how to get there in a routine and systematic fashion. So when we look at the study, and what we heard from the speakers this morning was that there is a trust that is created in this transparency. That's a key part of patient and family engagement. There is a notion of partnership between patient and family and clinician that is really reinforced by allowing patients to see and actually give feedback and have a dialogue about what is in their record, including in their note. It helps us move away from this notion of patients as passive recipients of care to being actively involved in their care. We heard about how it helps them better adhere to medication regimens and understand their care plans. And perhaps most interesting, I think, to me, we heard a lot about how Open Notes helps to reinforce clinical perceptions of patients as a whole person, right? And really explicitly requires us to think about the language that we use when we're writing a note, so that when the patient reads or the family member reads it, we're taking into account and having a respect for their reactions. And I think that helps the care team really move to understanding patients as the individuals that they are. So that kind of partnership and trust and activity and whole person orientation is exactly what patients and families say helps them get to better health outcomes. So I think this is a very simple concept with profound implications. Now, that being said, doesn't mean everybody's ready for it, right? So that's what we want to turn to our panelists today and hear from each of your perspectives. So just starting, broadly speaking, with the question of what do you think your constituencies will think of this idea? Before they read the study, when you pitch them in the hallway or on the elevator or at the water cooler, what do you think that they'll think? So let me start with you, John.
Well, in many respects, I think I have an easy task, because I can assure you from a consumer point of view, when I think consumers hear about or will hear about Open Notes, they're universally pleased, they're satisfied, they're impressed. It's wonderful. Frankly, I think when you look at this data, most consumers are going to say, so this is somewhere between a, well, duh, and a no-brainer. Which means they're very unsatisfied with the system. They're very worried about the system. They're very worried that Tom and Jan are going to follow in the footsteps of Atul Gawande's surgical checklist, of Peter Pronovost's hospital infection approach. Those look like no-brainers to us. They're going to remember that the average time to implement a no-brainer in the healthcare system is 15 to 17 years. And they're going to ask, why do I have to wait? I'm in Yonkers, New York. Why do I have to wait for somebody to be enlightened like the folks are at Beth Israel? Why do I have to put up with a system that maybe is 20 to 30% early adopters who figure these things out and do them right, maybe 25 to 30% folks who are completely disorganized, on the verge of bankruptcy, fearful for what's going to happen to them tomorrow, and a middle group of 40% who aren't quite sure what the heck they're going to do. And so I suspect this will be an issue that some consumers will be SOBs about, and they should. And so really, the issue today isn't open notes, it's what's next for open notes, and Tom knows that, Jan knows that. It's what the rest of us will do to get this done in less than 15 years.
Great point. So, Steve, from a physician perspective.
Well, thank you. So I've actually struggled to think about what points I wanted to make. So I'll get a few out there that are just easy. My colleagues at the AMA pulled for me 10 pages of ethical and policy statements we've had over quite a long time. And patients have a right to access to their medical record. There's no dispute in that. That's shown by law. It's medical ethics. It's a hallmark of behavior of physicians and clinicians. It hasn't always been easy. I mean, it shouldn't be difficult. You just request a copy, they photocopy it, they give it to you. It shouldn't be difficult, but it hasn't been prevalent. You have to really be a motivated patient probably to want to have a chronic illness, have a real commitment to your care. Remember, 50% of Americans consume less than 3% of the healthcare dollar. Yesterday, Delta Airlines messed up my travel for the third time in 7 days. And so as I was leaving the airport so I could come this morning instead of yesterday, I was intoxicated, and I was looking at my cell phone, and I ran smack dab into a steel beam, a little mark on my forehead, and chipped my tooth. And so I went to the dentist yesterday afternoon. I didn't expect to do that either. And he fixed my tooth. Now, he has a medical record for me. It's going to say how he put that amalgam on my canine and he fixed it. I don't really care what's in that record. Never going to look at it. My tooth is fine. It doesn't matter to me in the least. So there's just one example of the countless number of patients in the United States who aren't going to give a hoot what's in that record, because as far as they're concerned, they had a very simple, time-limited issue and it got fixed. There are going to be others who have chronic illness. My daughter is one of those patients. There's going to be other patients who just have a strong commitment to their health, and this could be wonderful. Technology makes it easier when we get there. The current iteration of health information systems and electronic health records are a real pain in the keister for a lot of us, patients and doctors. I think we have to figure that out and get past it. And so as much as I hear the excitement and as much as I share it, because I give patients copies of their data when they leave the emergency department after I see them, I also have a little bit of a hard time with the same magnitude of enthusiasm, because I have to agree, there is a bit of the duh, why not? So just make it happen. I'll ask one question, then I'll stop. The interesting thing, it appears that only the patients were asked about privacy concerns and not the clinicians. I think it's fair to say that the physicians tend to overestimate the risk and underestimate the benefit. The patients tend to overestimate the benefit and underestimate the risk. And yet here is one question asked only of one half of the population, where 30% were concerned about privacy, and yet this is only releasing their notes to them or someone they designate. And so I think that that's a question for the investigators to look into later.
Chantal.
Sure. Well, I thought these were really interesting research results, and it's clearly a part of the ongoing trend, right, toward use of technology and transparency in all aspects of the economy, not just healthcare. And I think there are some great questions that we want to look into as we think about, as I did, what would you do if you took something like this out of a primary care practice setting, which was the setting of the research, as I understand it, into a hospital inpatient stay. And I think this is a little bit along the lines of what Stephen was saying. This is one of many tools that people are using today to think about how do we do patient engagement better and how do we bring everybody into a team. And I do see potentially the role of the online note as part of those things that are underway. And the AHA and the whole hospital community has been doing a lot to sort of highlight best practice and change behavior around patient engagement. And some of the things that are really showing a lot of promise are things like doing handoffs from one shift of nurses to the other at the bedside. And so there you have the human interaction of this is what we're doing and this is what we're planning for the next shift. But could that be accompanied by, and here's the record and let me walk you through what the doctor said? I think that's an interesting question. I do think the inpatient setting has some, some of that real-time question of what's the patient's condition? Can you have this technology available in the room? What is the volume of data that you're looking at? And do you have that interpreter that could take the 3 different specialty consult notes and boil that down into something that can be shared, that translator interpreter role. So I think it's in the inpatient setting something where we should really look and do some work to understand how this becomes a part of what we're doing to create better understanding in the patient and their caregivers and their families of what is happening real time.
So let me try to put a finer point on it. I think, Chantal, you said 2 things that are really intriguing to me. One was your analogy to change of shift at the bedside, which I think is right on. I thought about that notion, and I thought about rounding at the bedside as well, so patients and families can be involved in the hospitals that are doing that kind of work collaboratively with patients and families are showing some really terrific improvements in quality and safety. So I think that's a great analogy. So I think the other piece that you said was, the note as one part of what's already underway. And I think, as we all know, there's a lot underway in technology policy in the U.S. today. So to try to put sort of a finer point on it, I'd like to understand what you guys think are both obstacles and enablers, but I want to frame it in the context of a very basic question, which is, should open notes be part of stage 3 of meaningful use, the EHR incentive program? And I'll ask that knowing that there are already 2 pieces in meaningful use stage 2 that could be enablers. One is a menu option where 30% or both an eligible hospital but also an eligible physician can record one electronic progress note for 30% of patients. And the second is the view, download, transmit construct, which is can include something like a portal. So we seem to have at least some technology groundwork laid in that program. But if we think about it in that way, which is a very real opportunity, what are the obstacles? What are the enablers? Is that a realistic notion to get there for stage 3? Steve?
You brought meaningful use into it, which kind of
I had
to. Meaningful use, I think one of the things that the clinicians, probably the hospitals, bristle against is all the mandates and requirements, and it's getting so hard. I mean, we're not even through stage 1 to even know what the heck's going to, we know what's in stage 2, but it's so many years down the road, and the technology's moving and changing so much, and so many of the people implementing this have their eyes right in front of them just trying to get the systems to talk to each other and implement it. So I don't know. My view would be that once we make available access to patients' data, I would think if there's the proper protections for their privacy, they should have access to whatever's in that record, whether it's the clinical notes that the clinicians wrote, whether it's the laboratory data, whether it's the procedure notes. I don't know why we segregate one category versus another. I do think that there are concerns from the provider community about HIPAA and privacy, because we already have it when we hand paper documents to people and they toss them on the floor in the waiting room on the way out, or they leave them in the room, and now their personal identified information is sitting loosely. So I guess the proliferation and the propagation of the data, that's a new world, and I don't think we should be fearful of it. I think we should address the concerns as they arise. But remember, there are massive damages awarded and awards against providers who violate HIPAA and have these privacy breaches. So this should not be a reason to not move forward with sharing the data with the patient. But when you hear some who jump out and say, wait, you can't just tell me to do this, they have legitimate concerns. So if we address those, make the whole thing available to patients, let them have access. I'm not fearful of an informed patient. That's better for the patient. and it's better for the care team. And will it change the way we write notes? Will it change the content? Will it change our behavior in the interaction? Sure, that's not new. It's been happening since Galen and Hippocrates. It'll continue to change, and that's fine. That's the way it is.
Chantal, John, their view?
Sure. And I think this falls in the realm of best practice and education and moving forward. And I don't know that I'm ready to answer the question, particularly on the inpatient side, because what we have is a pilot project on the ambulatory side. But I think it's something to look at and learn from and understand. Since we're talking meaningful use, the AHA did ask that clinical notes be part of stage 2 because it's important to have information electronically so that you can share it electronically. And so I just think there are a lot of questions to be asked and answered between now and then, but it's part of the record and should be available.
Well, I mean, I think that strategies and infrastructure are important, but Americans loved cars before we had an infrastructure across our country to build highways. I can certainly envision a day when medical record systems will have, a open notes package, and it's up to you to press the button, and it'll cost you some for that package. And I'm sad to say some people will probably choose financial packages over open notes packages, and so that's a war we'll have to fight. But I think right now the attractiveness here is this is a culture issue. This is a culture tool, culture beat strategy. The interesting thing is the degree to which folks will take this on as a way to change the culture, to ready the world for those strategies. Our sense is that consumers trust doctors and nurses more than they trust anybody else. They trust them more than they trust Consumer Reports. And strategies that link consumers to doctors, that build trust, are winners. They are winners. Consumers don't trust systems. They're not going to trust them. They don't trust CEOs. They're going to trust their doctors, and they're going to trust their nurses. And to me, the folks who have a sense of how to change the culture now are going to get on this.
Christine, to that point, I think, and I'm thrilled to be part of a profession that patients trust me. I think as an emergency physician, folks who come to the emergency department for the most part grade us after the fact on the same things they grade the hospitality industry. Was the room clean? Were people polite to me? Was the coffee okay? Did you get me a blanket? Did the television work? They assume or they take for granted that the quality will be there. I think that's at times a dangerous assumption. I think that as an individual human being, I'm as flawed as anyone else. And so I welcome the partnership and the collaboration with the patient. I'm grateful when they point out the errors that I make, and I welcome that. So, but on the other hand, I think that we shouldn't overplay some of these facets because most patients pick physicians based on a recommendation of a friend or a family member. That's how they pick them. It's not Angie's List or even Consumer Reports. And most people are not, notwithstanding the enthusiasm for open notes that they said I would pick a doctor based on that, maybe a primary care physician, but not for appendicitis, not for an ankle fracture and things like that that are more timely. You're kind of subject to the availability of what's there at that time. So again, I'm not trying to dampen the energy. I've seen a lot of things even in my short career where we've allowed the excitement to outstrip the reality or not to put it in the context. This is fantastic. This is part of electronic medical records and making things available to consumers and shifting the relationship between physicians and patients in much the way it has shifted over the years. It's a different kind of partnership. It's not the new partner. It's not a partnership for the first time. It's an evolution of that partnership.
So I think John's hit it right on the head, and I think you're getting to it too, Steve, which is this notion of culture and how do we address it. And I wonder if there are some discrete, small, easy, short-term wins that we, practical, tangible implementations that we might be able to do, because as I mentioned when I opened, I do think this is potentially a very important gateway into really meaningful patient and family engagement. You know, we talk and have talked for years about how we wish patients would take more responsibility or get more active in their care, and this is really, I mean, what the study said is this really does actually enable that, and I think it is a identifiable and discrete thing. But I think that, you know, John said it, where we really get into some cultural barriers and hesitance. So I want to read one thing that came actually from Michael's editorial. I don't know where he still is in the room, but I'm sure he's here, that I thought was particularly powerful from a consumer perspective. But I'd love to ask you as a panel to really talk about how can we address the sort of cultural you know, barriers and attitudes among the physician population who either chose not to participate in this study earlier, right, as the study described, or who may have left the study partway through. How do we get to that population, which is by far the larger population? So here's the quote. I remember this history when I hear doctors object to making lab reports or visit notes available to patients because they may cause pain and anxiety. No doubt they will in some cases, but then pain and anxiety are part of the human condition and are as likely to be produced by a sense of ignorance and powerlessness as by knowledge. The difference turns on who decides. And I think that notion of information as empowerment is really, really key here. So how do we get to the cultural piece, or what are the strategies that we could pursue in the short or medium term to really move this forward? You guys have thoughts? And then
Well, I mean, our sense is just the more doctors and nurses and patients communicate in every way possible, the better off we'll be.
I think there are a lot of things that can be done, not only on the culture side, but on the technology side. Getting back to usability, make the right thing to do, the easy thing to do. We don't necessarily have technology products that actually would make this as easy as you know, the homegrown system at Beth Israel, which is fantastic. So that's one piece. And then I think, you know, what's happening today and the coverage of this study is all part of what will change that. And you know, it's a two-way street, right? So there's the push within the health system, and then there's the pull from the consumer. So asking for and offering is really kind of how you get to that middle. And I'm still, you know, looking at from an ambulatory side, we have some great evidence. I'd love to see more done on the inpatient side to help us understand how it works there.
I think just understanding the fears and the concerns that lots of the different stakeholders are going to have will help. I think if the Geisingers and the Harvard teaching hospitals of the world, and not to leave out Harborview, but I'm picking these iconic names that you hear in all these sort of settings, if they go forth and they take on these issues and they make it their early competitive advantage, it's going to propagate on its own. It's going to get out there. It doesn't mean that there's not work to get it to propagate. You're going to have to do that work. And then Consumer Reports highlights these things, and then before you know it, it becomes more obvious. I have a sneaking suspicion I'll see this in a stage 3 discussion somewhere at a theater soon. And so I think that there is another vehicle where this is probably likely to emerge. You know, it works good and bad, right? The EMR spits forth gobs of volumes of data. Much of it is gibberish and not useful to anyone. So someone like me types a little paragraph to the patient. I think this is your problem, and this is what I think is going on, and I think you should do the following. And your data is all attached to this. That's with me using paper to supplement the electronic environment. On the other hand, patients can get access to data and get confused and upset. You know, some are helped and some are harmed. But that's the present reality too. We'll just shift who has the help and the harm. And hopefully, as long as that trust continues, John, that you mentioned between the doctors and the nurses and the patients, and we keep working together, hopefully we continue to edge toward a better place. And this will be one of the useful tools that can help us to do that.
Great way to close. So let's go ahead to some questions in the audience. And I see we have a number of hands. Always exciting. Hi, Suzanne.
Hi. Suzanne Mintz, National Family Caregivers Association. I agree that patients and families tend to trust doctors, but they trust peers even more. And I think when some groups, you know, start getting involved in something and the grapevine and the social media get involved, that indeed is one way to move things forward. But the issue of HIPAA came up, and I do think we need to address that, because even though it says that you don't need signatures and doctors and other professionals can let families see notes and whatnot, it's still used as a huge barrier to allowing consumers access, and I think you have to fight that battle at the same time.
We'll go to this side of the room if Andrew's ready. Here we go. Yes, sir.
I'm Tom Feely from the University of Texas MD Anderson Cancer Center, and I want to congratulate everyone for getting this published and getting it the academic credibility that I believe it deserves. At MD Anderson, we've been doing this since 2009. We provide it for 100% of our patients. We mandate that all of our 900 cancer specialists participate. The conditions of participation are they're salaried physicians. We don't let them opt out. Why did we do it? We didn't do it out of a research program. We did it because, number one, we could. My boss, Ken Shine at the UT system, said transparency. Ken was the president of the Institute of Medicine, and he said, you have an electronic medical record and a patient portal, do it. At the time, I was vice president for medical operations. I said, yes, sir. We turned it on with a flick of the switch. It was one of the cheapest IT projects we did in the time I've been, the 15 years I've been at MD Anderson. It cost us almost nothing to do. The fears that the doctors presented to us about, oh my gosh, I'm going to spend more time with my complex cancer patients in the clinic, disappeared as soon as the switch was flipped. They spent less time. We turned everything over. All of the notes, not just the physician notes, all of the multidisciplinary care team notes, and our patients love it. Our focus groups have indicated that our patients use it. They use it because cancer is complex. Some of our patients have said, we leave the doctor's office and we've been just overwhelmed with information, and we go back home and we can read about what really happened and refer back to it. It's a very profound cultural change. We do it also because 2/3 of our patients don't come from Houston. They go back to their communities, and we give our referring physicians the same access. They see the same things that we see. The only caveats we did with cancer patients was we put a delay on laboratory testing and pathology and diagnostic images, because we don't want our patients to be the first one to see that their tumor in their liver has progressed in size, or that their CEA antigen has risen. We want to give our physicians the 7 days, which is the window, to call them and let them know that there's going to be something that they're going to see. Our patients want more information. They want more explanations. They want the thing that hovers over it that says this is what the SOB stands for. We know our physicians have changed how they've documented. We haven't studied it. And when this came out, I thought, well, I'm the lowly Texas professor, and Tom's my old friend from the 70s at the BI, who's the Harvard professor, who's studying it. We need to study it more. But my comment to the group is, I think we really need to get patients to understand that this is something that they should demand, because physicians will not automatically do this. We did it because we were told to do it and we thought it was the right thing. But this has to come out of a consumerism, and I just hope that the panel, in terms of dissemination, can really work to make this an important cultural transformation. I sit on a committee on the Institute of Medicine, and earlier this week it's on the quality of cancer care, and we're trying to build into our consensus this type of recommendation that we turn over the notes to our patients. IOM things, as you know, take some time. We think this can be done quickly and easily, and with consumer support, it will happen as a cultural phenomenon that will change healthcare. So thank you for what you're doing. That's great. You could have been a panelist. So we're going to take one more question right here before we close for the day.
Quick question or a comment. I noticed that we have representatives of the Veterans Administration here, and the Veterans Administration has done enormous good in terms of quality improvement over time. And another program that RWJ supports, the ECHO program, is being adopted across the country, and the VA is leading. The VA could lead in this because they have a terrific electronic record, and they could make this available to veterans around the country and given the fact that the record is shared among all the VA facilities, this would be a great opportunity to push this forward if the VA stepped up and got engaged in this. So I urge them to look at this very carefully. Right, okay, so
Right, and so
it's
if we
underway.
can get Blue Button to include notes, I think we're in business. So, yeah, John.
If I could, I failed to disclose. I was fortunate in a previous life to be at the Portland VA and had patients look at my notes for some time. My experience was exactly the same as Tom was reported.
And
it's terrific.
Can I just make a comment? This is Kathy Frisbee from the VA, and we are, in fact, piloting a project right now to expose progress notes to patients.
Great.
And our intent is to do that across the enterprise.
Great, thank you. So please join me in
Can I just
thanking
make,
my panel
I'm sorry,
this
one
morning.
just quick in answer to your point earlier about inpatient. So Mark may not have encountered this because he rounds later in the day than I do. But we now walk into patients' rooms and they're sitting there on our portal hitting refresh, and they're getting the labs faster than the house staff who are rounding with a piece of paper.
Right.
So when our open notes goes live for all notes, including inpatient notes, any note in the system, they will see those instantaneously. So we will very quickly be able to know what happens in the inpatient setting.
Thank you.
And
Please
we'd
join me in
love to
thanking
know
my
that.
panel this morning. Good job, guys. And please welcome back to the stage Risa Lavizzo-More.
Great. Well, I, for one, have really had a great time today. I think it has been a very stimulating morning. I want to thank Tom and Jan for getting this all started with your research, and to the 3 centers that stepped up to be a part of the study, and MD Anderson. It was a wonderful discussion that you added to. You know, I do think we are looking at a culture change, and it is one that will have some twists and turns. They're never linear, but I was just shown a tweet that says this open notes thing is gaining momentum, and it is. We had a good discussion today. We had a lot of very important questions asked, and I think what I took away from it is that we're going to have to learn as we go. We had a series of questions, and I put them into kind of 3 buckets that I'm going to take as a challenge to all of you. First, we had a lot of questions about what we can do to help other leaders around the country embrace this in a way that actually benefits patients. We had a lot of questions about the barriers that we still face. And most importantly, we have questions about how to address those barriers so that we can, in fact, learn as we go and create this culture change that needs to happen. So my challenge to you is to join us online to help answer those questions, and most importantly, to really keep the momentum going on this Open Notes project that I think has the potential to be a game changer. So the challenge is yours. Join us online, and thank you for being here.